right, let's get started. Esteemed colleagues, good morning, good afternoon, or good evening from wherever you may be joining us. Today is the first of what we hope will be many webinars put on exclusively for members of the EIM Global Health Network. These webinars are part of an ongoing effort to provide an enhanced level of technical assistance and support to all of the EIM National Centers, part of the EIM Global Health Network. Our intentions are to host these global webinar series every 2 to 3 months. As part of this series, we plan to rotate between two different types of webinars. The first type are those that provide technical assistance, such as today's webinar, as well as others on expanding EIM on campus in your country, developing an EIM credential program, and marketing and fundraising. Our second type of webinar will highlight the work of other EIM national centers, allowing you all to share your secrets to success and lessons learned implementing EIM in your countries. If you have requests or ideas for future topics or wish to present a webinar on the work of your national center, please let us know and we will do our very best to work you into the schedule. Before we start today, a few technical items. First, we have muted and turned off the cameras for all webinar attendees to eliminate background noise and distractions. If you have a question as we advance through the presentation, there's a chat function at the bottom of your Zoom toolbar. Click on this button and a Zoom group chat bar will appear on the right of your screen. Type in your question and we will do our best to address it before the end of the webinar. This will help us limit interruptions during the presentation. Second, this presentation is being recorded. We'll email a link of the recording to all National Center directors and managers to share with advisory board members who could not attend the webinar. Finally, the PowerPoint presentations from the webinar will be made available afterwards. Please write us with your request and we will share the slides with you at a later time. Having said all of this, if there are no questions, and remember, use the chat function if you do have a question, let's begin with today's webinar titled The Exercise Medicine Solution and 4 Pillars. We decided to start with this topic, which I'm sure that many of you might have heard over the years from myself or other members of the EIM team, for the benefit of our new members to the Global Health Network, and to also serve as a foundation for our future presentations where we'll examine specific sections in greater detail. So, at the very basis of exercise medicine, our founder and chair once said, what if there was one prescription that could prevent and treat dozens of diseases such as diabetes, hypertension, and obesity? As a physician, would you not prescribe this to your patient? And the answer is, certainly you would. So physicians should prescribe it and patients should take it. But this is not what's happening in the real world. And many of us are beginning to ask, are we reaching a point where not prescribing physical activity should be considered patient neglect? When you look at some of the data that is coming out, we see that healthy behaviors plays a significant contribution to what makes us healthy. However, when we look at how our money is being spent, it's a very small percent on promoting healthy behaviors. So why is this? Well, perhaps it's because of a lack of patient engagement. Perhaps because the clinical care setting just simply does not have the infrastructure and knowledge to engage patients in lifestyle change. So that's where the EIM solution comes in. We wanted to create a community-based extension of healthcare for at-risk population groups that provides a cost-effective approach while providing a high level of care and support for our patients. Exercise is a global initiative. Exercise is Medicine is a global initiative to establish physical activity as a standard in healthcare. It was first established in 2007, and by 2008, we were already expanding across the globe. Our vision with Exercise is Medicine is to make physical activity assessment and promotion as standard in clinical care, connecting healthcare with evidence-based resources for people everywhere and of all abilities. As you can see, our global health network has quickly expanded. We have now 32 countries with signed MOUs and several others on the way. A number of years ago, when we published an article in the British Journal of Sports Medicine, we created this logic model with inputs, activities, outputs, and outcomes. And today we're going to focus really right at the heart of this, where we have the clinical integration working hand in hand with the community integration. And we do this through what we call is this exercise medicine solution. And we look at three key elements that we believe should be adopted to establish physical activity as a standard of care. First, we have healthcare systems, then connecting to the community resources, and then through all of this is the consideration of how we use active health technology. So let's start with the healthcare systems. In the healthcare system, they will adopt the EIM solution by integrating physical activity assessment, prescription, and referral into their system. So here we have it, and we'll break this down shortly thereafter. But first, again, physical activity assessment, prescription, and then referring our patients to a physical activity network. We believe that this all starts with the physical activity assessment and ensuring that a member of the healthcare team assesses a patient physical activity levels at every clinic visit. We, with Exercise Medicine, promote the physical activity vital sign, a simple 2-question survey that can be done in 30 seconds and tells us how much a patient is doing in terms of physical activity, frequency, duration, and intensity. The PAVs can be integrated into the EMR to ensure that every patient is being assessed at every visit. EMR software can then be programmed to calculate the physical activity levels in minutes per work, so we can then compare to national physical activity recommendations, i.e., are they meeting 150 minutes per week of moderate intensity physical activity? And this is what a snapshot of how it looks like in a EMR, where it pops up and you can see here how many days of moderate to strenuous activity is one doing, and how many days per week is this. Multiply these together, and we get the number of minutes per week that they're doing. The physical activity vital sign has been implemented in many or several large healthcare systems across the United States. Kaiser Permanente, where Dr. Salas works, was the first to adopt it in 2010. Later in 2013, Intermountain Health also adopted it across all of Utah and their surrounding regions. There's plenty of articles on both, research and articles on both of these adoptions. We'd be happy to share with anyone later in the future. Looking at Kaiser Permanente and their adoption in 2010, in the first 1.5 years of implementation, they had nearly 86% of all eligible patients had their physical activity levels assessed and recorded in the EMR. A couple of years later, they wanted to look back at those physical activity assessments, and what they did is they examined these nearly 1.6 million visits in a health system, a Kaiser health system that had the PAVs in the EMR, and they compared it to outcomes in other Kaiser hospitals that had not yet implemented the PAVs in their EMR. So they're comparing patient outcomes who had their physical activity vital sign assessed and hospitals where patients did not have it assessed. What they found is that in the hospitals where they were assessing the physical activity levels using the PAVs, they saw an increase of 12% of documentation of physical activity habits. Patients were 14% more likely to discuss exercise with their primary care physician, and a 14% increase in providing exercise referrals to patients. Further, the use of the PAVs, we saw a small, very small, but significant weight loss in patients that were overweight and obese. And we saw a small reduction in hemoglobin A1C levels in patients with diabetes. All of this from asking 2 questions that take 30 seconds prior to the physician visit. The second step in the healthcare system section is the physical activity prescription. Using information from the PAVs, the healthcare providers can provide patients with appropriate physical activity prescriptions. These prescriptions can be based on ACSM evidence-based guidelines or guidelines from your own country or from professional organizations. Then these prescriptions can be given to patients through a variety of tools and modalities, which I'll discuss in a second, and they're filled through referral to existing community resources. So the original and most famous physical activity prescription example is the green prescription in New Zealand, where the Ministry of Health adopted this system of providing patients with a written physical activity prescription. In a study at the end of the 20th century, they found that providing a written prescription resulted in a much greater, 32% greater increase in physical activity levels than just providing patients with verbal advice and counseling. Later, another study backed up these results and showed that providing an exercise prescription increased the number of patients that engaged in 150 minutes of weekly physical activity. Here in the US, a couple of years ago, our clinical practice committee developed this exercise prescription pad. This is side by side here, but in reality, the left side of this will actually be the front of the pad with a very brief description of what these numbers and prescriptions mean on the back side. We've seen similar pads, prescription pads developed in EIM Canada, EIM Australia, where they've printed it out and provided it or given it to their healthcare providers to encourage doing physical activity prescriptions with their patients. We also at the EIM Global Center are developing Prescription for Health series. Here on the right, you can see this is for a provider, something to educate providers on losing weight in this example, and this one is done in Spanish. What we're really focusing on right now and we'll be releasing in the next few months is a patient-facing version that's more visual, more simpler to read, has between a 6th and 8th grade reading level, and this is really designed for providers to print out to be able to give to their patients to take home with them. But in both cases, you see examples of prescriptions that are helping guide patients in being physically active with different health conditions. Other unique things that we've seen that have popped up around the US and different parts of the world, one of them is this park prescription program. It's a very simple concept that physicians and healthcare providers are giving patients a prescription to go out and enjoy nature in green space. Another example that we saw here was in 2014 in Boston to try and address some of the health disparities in low physical activity levels in underrepresented populations of Boston. They allowed the physicians to prescribe a prescription to the local bike share program for only $5 a year, and they enrolled 100 low-income residents. I think both the park prescription program and this bike prescription program illustrate examples of unique ways that we can capitalize on existing programs in our cities and our countries to try and connect healthcare patients to these programs. The third area of the healthcare system module or section is probably the most important, and this is really referring and connecting patients to existing physical activity resources in the community. And this might include directing patients to self-managed physical activity programs. Other patients might need more structured programs that meet their individual health needs. And overall, we're looking to create a network of programs, places, and professionals that we can use to pull together and refer patients to these different resources. One of the more common and widely spread referral schemes was and is in the United Kingdom. This started again back at the end of the 20th century through the support of the National Health Service. They developed these exercise referral schemes, and by the 2003, this was really the peak of the ERS, and they had more than 800 referral schemes in different sections across the entire country. The government endorsement was a huge factor in this and a rapid increase, and it's actually become ingrained within their health system that this referral to community resources and programs is now an integrated part of their healthcare system. When evaluating these schemes, they show that patients had increased their physical activity levels 27 and 21 minutes at the end of 12 weeks and 1 year later. So definitely some success with these programs, and even more so the government involvement and the long-term integration into the healthcare system. Similar, there was a study in 2005 to 2007 in Sweden, in this one region of Sweden, where they got all of the providers to give physical activity referrals. Patients are provided with a single prescription and a follow-up call, very important, a follow-up call, to ensure that they attended and followed through on their prescription. During a 2-year period, they providers gave out 6,300 physical activity referrals, and you can see here the results. At 3 and 12 months, we saw a significant level increase of physical activity amongst the patients. One thing I'd like to point out here is in this study, the profession of the prescriber, whether it was the physician, a nurse, or some assistant in the office, was not associated with effectiveness of the prescription. So it did not matter who gave the prescription. It was more important that it was just given to the patient in the first place. When we started Exercise as Medicine, one of our visions was to have an electronic referral network here, something the providers in their office could go into, click in a zip code, and it will provide a list of all the different resources in the community. We haven't quite realized this yet, but I think as we think of how to integrate technology into what we do, this is certainly where we want to get to, is that simply a provider can look it up and give a patient a printout of all the existing resources in their community. One final example I'd like to discuss about the referral process had to do with a study with breast cancer survivors done here in the Northeast United States. Breast cancer survivors were referred by their oncologist to physical therapists to complete an evidence-based strength training recovery program. The referral was entered into the EMR. Patients were provided with a printed copy. What was nice was that the participants or patients were reimbursed for the physical therapy through their healthcare insurance. This study showed that it was safe for patients to be referred to physical therapists, and that when they did go, it led to improvements in muscular strength and body image. I'm going to come back to this study in a little bit, but I think this is a nice example of how we can tailor referral schemes for different populations, in this case, breast cancer survivors. So at the end of the clinic visit, we have an end goal that no patient should leave a physician's practice without having an assessment of their physical activity level, receiving some sort of exercise prescription, and a referral to qualified exercise professionals for further counseling and support. Now, the second section is this community resources and utilizing them to make sure that we support patients in their efforts to increase their physical activity levels. In establishing a physical activity network, we really want to develop a network of physical activity resources that consist of 3 different things. And we're talking evidence-based programs in recognized places by credentialed professionals. And the network can consist of resources to patients both in healthcare settings and in the local community. A lot of times our healthcare settings have a lot of in-house programs, so that's definitely a first place to think of referring our patients. But in other cases, the healthcare setting cannot handle the large number of patients that might be referred, and we absolutely need to tap into our local community. Another thought is that networks should also consist of self-directed programs that patients can access on their own time using print materials, online resources, and mobile technologies. So here's that physical activity network, again, with the professionals, programs, places or resources, and those self-directed programs and opportunities for individuals. When we're thinking about recognized EIM places, there's just a multitude of places in every community around the world that offers some sort of supportive physical activity resources. A lot of times we're not capitalizing or linking our patients properly to them, but if you stop to think about it, there are a numerous number of resources out there for everyone to explore or to go to be more physically active. When you're talking about physical activity programs, we're really looking at evidence-based programs that have structured physical activity. Over the last 2 to 3 decades, we've had fantastic researchers in the field developing evidence-based programs. It's on us as implementers to tap into those programs, to help implement them for our patients or help community members implement them for patients. So that's a second consideration, is making sure that the programs that we are referring patients to are of highest quality. Some countries may choose to certify these programs and give them a stamp of approval. That's a more advanced step, but certainly thought towards what are the types of programs to which we are referring our patients. Lastly is that credentialed exercise professional. And this is another step when developing that community resource or community network of physical activity resources, is how are we certifying exercise professionals to work with at-risk patients? We've seen over the years physicians constantly telling us we don't know what that certification means or what that credential means. There's a lot of fear and uncertainty where you can pick up credentials in 24 hours overnight. So it's really, as a national center, how do we differentiate between those who we feel are eligible to work with patients referred from the health system and those who may not be quite as trustworthy or qualified to do so? So this is this is how our healthcare system linkage with community model works, right? We have our healthcare systems. We described the 3 steps that happen. We have our network of community resources, programs, places, and professionals. When we started this, we thought, okay, so there'd be an easy flow from the healthcare systems, patients going to these community resources. But along the way, we realized it wasn't working. And there's numerous studies that are coming out now showing that this referral process doesn't quite connect patients the way we thought they do. And there's kind of a missing link here in the middle. And we've kind of learned along the way now that this role, or we need a connector in there, an intervention advisor that can help with enrollment into the programs or at least assess readiness and assist with the referral and follow-up process. You may find in your context this is not necessary, but in a lot of our work in research and real-world examples, we're seeing more and more that this connector is really quite important to get patients to those physical activity resources. So these intervention advisors can really be anyone, and they can be located in the healthcare setting, or they can kind of come from the community side of things. In the healthcare setting, they might be referred to as care managers, navigators, sometimes nurse navigators. There's a multitude of roles of people who may take on this role. Now, it's important that these people have some training, behavior training, basic understanding of physical activity, knowing what those community resources are. But these are the individuals who can really reach out to our hard-to-reach patients, empower and motivate them to be more physically active and follow through on that prescription from their provider. So going back to this study I talked about previously with the breast cancer survivors, one thing I failed to mention is, yes, when the breast cancer survivors went to the physical therapist, there was a great success with in terms of outcomes. However, early in the study, none of the survivors that received the referral actually went to the physical therapist. And so for the first year of this study, it really wasn't working. And so the research team had to go back in and do a little exploration to see where the breakdown was. They worked with the physicians and nurses, and they realized it was crucial to have this staff liaison, this intervention advisor, to serve as an intermediary to help with the referral process. Once this person was implemented, the referrals were much smoother and patients started going to the physical therapist. However, even with the help of this liaison, patient engagement, those who received a referral and went to the physical therapist, was still only 23%. And somewhere between the 25 to 30% range of patients engaging that receive a referral is what we're seeing as quite normal. So just something to keep in mind as we go forward, as you go forward with your efforts. So at the end of the day, we have this healthcare systems and community resources. And somehow we have to build that bridge of trust. And in every country, in every setting, in every context, it's going to be a little bit different how this bridge is built. You may need an intervention advisor, you may not. But we have to, at the core of exercise medicine, figure out how to do this connection to get our patients to physical activity resources, whether they're in the health system or located externally in the community setting. So the last module of the three that we talked about is thinking about active health technology and how this can be used to track participation, conduct assessments, and report information back to the healthcare systems and providers. So we've already mentioned this, really just collecting using participant data to make sure that we're on top of it and using the latest technology to help us in this whole complicated system. And so as we go through, our technology is advancing, and it can be used at each and every one of these steps along the way, from assessment all the way down to reporting outcomes back. In some studies, we've seen that the physicians and healthcare teams are saying, listen, we refer patients out and we don't hear anything about what's happening back. And I know there's a lot of research right now going on with looking at how we can use our activity trackers and somehow connect that information back in a simple, easy to read format to the EMR system. So there's no limit to how technology can help advance the different steps we are going through with our patients, connecting them from the healthcare setting to the community resources. One thing we did here in the US is in 2016, we held a think tank to really look at the role and develop a framework for how technology could really be used to help promote the EIM solution. And I'd encourage all of you to read this article by our Felipe Labello in 2016. It's called The Wild Wild West. It's a really great article, and it will get you all thinking of different ways that maybe we need to be using technology or should be using technology as part of this EIM solution. So now here's our model. We have the providers of healthcare being assisted by intervention advisors, getting patients to these programs, places, and professionals. Not going to go into it today, but we also have to think about the payers of healthcare. Where's the money coming from, and how is this flowing and assisting the system? And also a little bit about public health and practitioners directing underserved populations that might not fit into this model to cost-effective physical activity programs. So this, ideally, down the road, is the entire model we're trying to achieve with our EIM solution. So the EIM solution is really engagement starting in the healthcare system, where providers and payers engage and refer at-risk population groups to the EIM networks of physical activity resources for participation in programs to combat all the diseases, obesity, and sedentary behavior that we're seeing in our society. So the second part of this now is something we came up with in 2013 at our annual meeting to try and help make it a little bit more real. I just presented a model that was really expansive, that involved multiple areas and multiple peoples. Well, how do we actually put this into practice in our national centers? So we came up with 4 pillars of the EIM Global Health Network. And at the core of these pillars was training of healthcare professionals, training of exercise professionals, implementing the EIM solution in community settings and diverse populations, and integrating the EIM solution into healthcare settings. So we're going to go through these briefly with a few examples from around the world on what different countries have been doing in the past to maybe stimulate some ideas and provide examples. So pillar number 1, training of healthcare providers. We're really looking to increase the level of physical activity offered to healthcare providers. And notice we say healthcare providers, we don't say physicians, because we realize that nurses and medical assistants and physician's assistants are sometimes spending more time with patients nowadays than the physicians themselves. So we encourage people to think about the total healthcare team and training everybody, not just the physicians. So this could include the number of training courses conducted and the total number of healthcare providers trained. In addition to current trained professionals, we also, in the back of our heads, are thinking, well, how are we going to train our future physicians and healthcare providers in medical school or nursing school or PA school, and the residents that are coming through the ranks? So one of the first examples in the Global Health Network was in EIM Latin America, where they used the train-their-trainer approach, where we trained, John Duperly was really in charge of this effort, trained the trainers from each country that then went back and scaled it up. And it was a huge success because over the 5 or 6 years they did this, they trained more than 5,000 physicians across the country. Now with changes to their sponsorship and funding, under Sandra's expertise and guidance, they are now working to transition this to an online training workshop to increase the reach to a larger number of individuals at a much lower cost. In EIM Singapore, they started out, again, nearly the same time with their own training workshops for current physicians, and they were offering these almost at a monthly basis. From there, interest grew so much that they began training all military physicians. This is a mandatory inscription of males in Singapore in EIM. So at some point in the future, all male physicians will have had training in physical activity that work in Singapore. Lately, they've integrated training into the family medicine residency program at one of 2 medical schools in Singapore. And I believe they're about to start this in the other medical school in Singapore as well. So that way all family medicine residents coming through, male or female, will receive training in physical activity. In Israel, under Nama's guidance, she developed a 370-hour course. Yes, 370 hours. It was, wow, that's intensive, for nurses that received a special certificate in recognition from the Ministry of Health. She's also provided one-day seminars to nurses around the country and conducted a different 90-hour course to family physicians on fitness and health. So certainly a lot of different options and quite intensive that fit her context differently than other contexts around the world. Then in Canada, some great job by Jonathan Fowles and his team that they worked with the Canadian Medical Association to pass a motion that there should be a national curriculum development that includes physical activity and exercise. I mean, this is just momentous to have this with the largest medical association going on record with exercise medicine saying this has to happen. So a huge success there. Another thing that they've done is they've created workshops that have received national accreditation from the government and different health organizations for 1, 4, and 8-hour workshops. So offering different options for people. The 1 hour is kind of a teaser to get them into the 4 or 8-hour workshops. In 2015 alone, you can see the number of workshops they conducted across the country. They've received funding for this work and just continue to truck on with all of this over time. Here at the EIM Global Center, a quick update. In 2017, we provided and made available EIM training course for healthcare providers. If you don't have this and like to see what we're doing, please email us. It's now being used across Latin America, where Sandra has translated into Spanish and now is putting it online. Singapore has adopted it and spread it, and I know they're also using a version of this in Taiwan. And right now we're working to transfer this also to an online format to expand the reach across the whole US. Another effort that's going on by our EIM Education Committee is we're doing a study. It involved nearly 100 healthcare providers from every field to examine the key physical activity categories and topics that should be included in a health professional training program. We figured that at the very core of this physical activity training, there's certain basics that every healthcare professional should know, whether it's the physical activity guidelines or the basics to providing an exercise prescription. So again, that article will be published, we hope, in the next few months, and we will share it with everyone when it is. Pillar number 2, training of exercise professionals. So here again, I talked a little bit about it when we were going through the module on the community resources, but really trying to figure out how we set apart exercise professionals that are ready to train and work with patients referred from health systems. I think, and most of us think that a lot of exercise professionals, based on their, foundational certification, may not have that skill to work with patients that have diabetes or heart disease or different diseases. So this training, at least in the US, is working with patients that have chronic disease, interacting with healthcare providers, and really utilizing behavior change strategies. Then how do we develop that referral database or referral network of EIM certified professionals. So some examples: in Singapore and Philippines and several other countries across Asia, they would hold training workshops for exercise professionals, not in the same room, but in 2 rooms side by side. One, the healthcare providers receiving their training, the exercise professionals receiving theirs, but then they could bring them together and discuss how the 2 different fields could work together. In Australia, they've gone about it a slightly different way, adapting their own context. Through ESSA, which is the host of Exercise Medicine Australia, they certify programs at universities to train accredited exercise scientists. Their advisory board feels that these accredited exercise scientists are more than capable of receiving patients from healthcare systems. And then once they receive this AES certification, they are then accepted as part of the Australian professional network, establishing that high bar for who can and who cannot receive patients or should not referred by the healthcare setting. In Spain, they've gone about it a slightly different way. They're attacking it in training professionals through the graduate programs. You can see they've adapted 2 master's programs to include physical activity and health and EIM concepts, as well in their PhD program. In South Africa, they produced an online training course for allied health professionals and exercise professionals that they can then disseminate across the country. In Canada, they developed a certification system where they said, okay, if you have these different types of certifications, you are eligible to be part of our network. They then charged a fee for those individuals to be part of the network, help generating a little bit of revenue. Then they provided specific resources for individuals in the network, including prescription pads, posters, gave them reduced rates on workshops, and access to an EIM Canada newsletter that was published every couple of months. Here in the US, we developed the EIM credential. And over the first 5 to 6 years, we credentialed more than 1,600 exercise professionals in the US. It's a start, but we'd like to see maybe 10 times that number to really address the need across the country. Right now, led by our leader, Robin, she's in the process of refining the EIM credential, developing a more extensive and comprehensive training course. Estimates right now will be 12 to 15 hours of online training, with the goal of enhancing basic exercise professional training with information specific to working with healthcare systems and providers. We believe this training program, online training program, will be available to people in the US in late 2019. And as we go about this process, we're more than happy to consult and share our lessons learned with anyone should you need it. Pillar number 3, implementing EIM in community settings and diverse populations. So this is really thinking about how we can expand the EIM solution to other populations and communities through healthcare. So universities and colleges, school systems using school health workers, employee wellness, and different populations as you see here. A few examples. First and foremost is EIM on campus. We have more than 150 registered programs, and I'm sure that number is actually creeping closer to 200. And there was such a demand that we actually developed a recognition program to identify programs that have reached a gold status or a silver or a bronze status. Just excellent work with that. Canada took this and ran with it, and they've developed over 42 programs across their country, which is quite amazing because in Canada, there's probably not much more than 50 or 60 universities or colleges across the whole country, and most of them have an EIM on campus program. It grew so big up there that they actually began hosting national conferences solely around the concept of EIM on campus. Around the world, we see more than 50 to 100 is our best guess, EIM on campus programs in countries. Australia, Hong Kong's got a number of programs, Japan started theirs, Poland, Singapore, and Spain. So really excited to see the growth of EIM on campus, and we're going to host a webinar on this specific topic later in the year to help provide a little guidance on this. We also feel that it's very important, as I talked about at the end of the EIM solution model, to think about the public health aspect and how we can spread EIM to underserved populations. This is an ongoing effort in the US. We have our own committee dedicated to addressing how EIM can better serve underserved and community health populations. So this is a clinic. This prescription pad here on the bottom right is from a clinic in a free clinic that provides healthcare to individuals that don't have insurance, and there's no fee for them. But even in this setting, there's still basic exercise prescription pad. Is it that full gold Cadillac model? No. But every patient that comes in still gets a very simple prescription from their physician to go back out and encourage them to be physically active. We're also looking to make physical activity counseling a regular part of annual wellness visits in these low-income settings for these individuals and really encouraging them to be physically active. Another example of working with underserved populations is actually in Indianapolis, where one of our EIM leaders, Nicole Keith, implemented this wellness referral fitness testing and coaching in their public health system. And this is one of the largest public and safety net hospitals serving the poor and underserved in the country. And what they did is they created an in-house weight management program that really focused on physical activity. And when patients would come in, they were referred to this program called Healthy Me. They received a physical activity assessment, functional screening. Then they were put in this individually tailored program. They still exercised as a group, but each person had theirs adapted just for their needs. This program had the support of the administrators of the whole hospitals who helped fund it, the providers that referred patients, staff, and patients. It was just a great program offered in both English and Spanish, and it continues on to this day, impacting individuals that might not have the resources to go out in the community and pay or engage in physical activity on their own. Next population, we're thinking about pediatrics. How can we get, especially with the growing obesity issues we're dealing with children and adolescents, how do we get them more physically active? There's been so much attention on the school system, but maybe there could be more effort focused on how to do this through the healthcare setting. So one of the big things we're working on is testing physical activity vital signs. We need different assessments for children that are up to the age of 6, children that are ages 6 to 11, and adolescents from 12 and up. And really trying to figure out how we can at least assess what level they're at, so then we can provide an appropriate prescription and connect them to those community resources. Older adults, probably one of the biggest things we have going on in the EIM Global Health Network, really looking at how to implement or adapt the EIM solution for older adults when we implement it in healthcare settings. A number of years ago in the US, we had a huge success of the government mandating screening in one of our systems. It's called a HEDIS measure, where they're supposed to ask all older adults whether they're being physically active or not. Some researchers are examining the use of whether the PAVS is the best assessment tool or whether we should be using functional screening. This has been adopted by our team in Taiwan, and they're really focusing on assessing physical functionality and frailty rather than focusing on PAVS. I think that's a great adaptation for older adults. And then lastly, thinking about the safety and effectiveness of those community programs. Remember, we're talking about certifying those community programs, making sure they're evidence-based and safe for older adults who might be inactive or frail when we're sending them out, and making sure that it's really a trusted source that we can refer our patients to. Almost done here, a couple more slides, folks. This one is thinking about individuals with disabilities. A couple years ago, we established a partnership with a large foundation here called Physical Medicine and Rehabilitation, and really looking at physical activity, making it accessible for individuals with disabilities. Sometimes we overlook this population of individuals. So really, how can we develop more resources and systems to support these individuals in becoming more physically active? And I think this is a really nice area of research or to focus on in implementation of the EIM solution. Last pillar is the integrating the EIM solution into health systems itself. And this is our ultimate goal. And when we're talking about doing this, obviously our goal is integrating that physical activity assessment, giving physical activity prescriptions and the referrals. However, as we do this, it might only be possible to do one of these four, such as with Kaiser Permanente, which is really focused on the physical activity assessment. Long-term goal is to do all three, but we can start with 1, 2, or 3 of these different steps. So a quick shout out to the team in EIM Qatar. Their Aspetar health system, which is the host EIM, has a whole program. It's in-house for patients, not just on sports medicine, but actually fitness assessments, getting that prescription, having EIM certified physicians and exercise professionals, and putting patients in cost-effective group exercise classes. They're currently working on expanding this system to the community setting. Perhaps the best, and this is the last example here, example of implementing EIM into health system is in Greenville, South Carolina. This is a really large health system that's innovative, that realized we have an issue, we need to connect our patients and get them engaged in healthy lifestyles. And if you want to look it up, we have the link right here down, eimgreenville.org. So there's a huge press release at the National Press Club. Jennifer Trill mentioned right here, or shown right here in the middle picture, is really the driver of all this. If you want, you can go to this YouTube link and watch the hour-long press conference. And we hope to get Jennifer on a webinar in the future to talk about the work that they've done. But really, some of the accomplishments they did is that it was adopted by their chief medical officer, implemented across their whole health system. The physical activity vital sign was integrated in the medical system. Every patient is assessed at every visit. They have these exercise order sets, which are really a coordinated prescription that can be printed out and given to the patient, along with a referral connecting to the healthcare team. And then they hired that intervention advisor. So last time I heard, they had one full-time intervention advisor to follow up solely on these exercise prescriptions, and they cross-trained 5 other staff members to help with this process as they go along. Those patients had referrals, were referred to all the local YMCAs in Greenville, South Carolina. They formed a tight partnership. We went in and trained all of their exercise professionals to make sure they're EIM credentialed, and those intervention advisors helped ensure that there was a smooth referral to these community, to the YMCAs. Not only that, Jennifer worked on integrating physical activity training into their medical school all 4 years. You can see that she did it across every module, every section of every year. There's also opportunities where her students are doing physical activity research and working with patients live to get that hands-on experience as part of their lifestyle medicine curriculum. So as a summary for this talk, exercise medicine is now entering its 2nd decade. We're in year number 11. Over this time, we've developed a strong framework, the EIM solution that we saw today, that can be adapted for local country context or even regionally or per city for people around the world. This isn't something you have to do. It's an idea, it's a model, it's a framework, and we encourage everybody to choose what works for them. Then we went into the 4 pillars of the EIM Global Health Network to kind of provide a starting point for each national center to kind of develop their goals for the year. Which of these pillars can we address the best? How can we address it? How can we think innovative? And that can help structure our conversations and sharing with each other. So we hope in future webinars to continue sharing successes of components of the EIM solution or people who are doing different pillars through these webinars. So with that, I believe we're done. Thank you very much for your time and participating. I don't see any questions in the chat box. If there's anything you need in the future, please feel free to contact us and we'll get back and help you with that. So with that, we will call to an end our first Global Health webinar, and we hope there will be many more and you'll join us in the future. Thank you very much.